And then if we're videoing it, they always have.
Just watch what you say, because it is on.
Oh, we are on, we're live.
Correct. Watch what you say,
Mind if I join you over here?
Oh, more than welcome, Chair, more than welcome, Chair.
where are you going?
I gotta find an outlet.
Forgot.
I like to be in the front row, but I guess I can't today.
It's done. I think they're like roots or something.
Probably wait till about 10 after, just to give people time to filter in.
Yeah, I've tried to rally the troops and,
Oh, hex break. Here.
yeah.
You know, it's not your feeling, just the way that things got scheduled and popped up at the end.
Well, people also thought we were buying lunch, and then they didn't bring lunch, and now they have to get lunch.
Oh boy, it's like the perfect storm, isn't it?
Yeah.
We're here for you, Mike.
I love it, love it. You know, like the worst case scenario, this is gonna be video so people can watch it at another time, so that's not gonna be the end of the world. But it's kinda nice when you got a bigger audience, just in case there are any questions and stuff.
What, this isn't good enough for you?
I mean, it's,
It's more than my usual, Katie, for people.
That's not true.
Well, if you got the online one, then you get a pretty good presence. What was my last one, like 70 people online or something like that?
Really? Yeah. Wow, that's great. Like, brain. That's awesome.
A lot of my lectures within a couple of days goes up to 600-700 views. Which surprises the heck out of me for such very nerdy subjects that I cover in such a nerdy way, but definitely an interest there, that's for sure. I'm kidding, I'll probably look for about 10 after. It shouldn't take me the whole time to get through this.
Oh, hi.
Yeah. Is there a way that you can edit this so you can kind of blank out this dead time in the beginning? You can't shorten it. You can't crop a video.
When July, MP.
Yeah.
Oh, you're live?
Yeah, but we're recording too, so.
Where at? YouTube? Mm-hmm. That's crazy.
I'm gonna mark it as private, there's only people from the clinic can see it.
Oh.
Yeah, have them fast forward to a certain amount, a certain level. It's gonna be about another 5-6 minutes before I'll get started.
Oh. That chiplet caught my mouth. Well, you got 18 people here, Dr. Mike, start talking.
Oh, really? Okay, we got a lot of people viewing in then. Okay,
18? Cool.
that's great. Okay, so we're gonna get started then. Thank you everybody for your patience on me getting started today. It's been one of those busy days like always. So I wanted to do this lecture, I've been actually asked to do this lecture so that we can have a little bit more information about how we monitor our anesthetic patients mostly, and that's with the capnography or measuring the carbon dioxide levels in the blood. Now, it seems like a complex thing when you first look at it, and the waveform is like, what the heck does this mean? But it's really not that difficult. It's actually fairly simple. So I'm going to talk to you just a little bit of background about what capnography is, what it tells us, what influences carbon dioxide levels, and then we'll go through several examples to show what normal is and several common abnormalities that we might encounter so everybody has a clear understanding for you guys, okay? Alrighty, good. So first, of course, the definition, I like to start at the beginning and all things. What is capnography? It is the measurement of the carbon dioxide level in expired air, so on an expiration or exhalation is what it is. And the monitors that we have usually give two pieces of information. One is going to be a number, and that number is called the end-tidal carbon dioxide or end-tidal CO2, and that unit is millimeters of mercury. and it's basically the pressure of carbon dioxide in that particular sample that they get in the expired air. And then you also get a waveform. So if you look at the monitors, you can see that there's going to be a wave that corresponds to the level of carbon dioxide that it measures. And what's nice about that is, as opposed to just a one-time number, we'll also now get a continuous measurement of the carbon dioxide levels through the respiratory cycle. So it gives you real-time information about what the patient is doing for us. And the value of measuring the end-tidal carbon dioxide levels give us a really clear idea of cardiac respiratory function for anesthesia. But it also has become the gold standard on how to monitor efficacy of cardiac compressions during CPR. And without the end-tidal CO2 measurement, we're going to have somewhat limitations on knowing just how effective our CPR efforts are. Okay? So now, it's going to be very basic, but I do want to review this because it does make sense whenever you start thinking about what carbon dioxide levels are and how they're formed and why, and the things that influence the carbon dioxide levels. So first, in our body, when our cells metabolize energy, it's going to utilize oxygen and then produce carbon dioxide as a waste product. That carbon dioxide enters into the bloodstream and is carried from the body to the heart. And from the heart, it goes to the lungs. And with ventilation, we're going to be expiring the carbon dioxide, replenishing the oxygen, and then that blood goes back to the heart from the lungs and from the heart to the rest of the body, and the cycle goes and goes again. So that means at the level of the carbon dioxide level is going to be influenced by three things: lung function, the ability of the heart to pump blood to the lungs, and the metabolism of the body. And as far as the physiologic factors that are going to influence the carbon dioxide levels, okay? Now I have it kind of written out, spelled out here. So the factors that affect the end-tidal CO2 levels are going to be ventilation, which is how much gas is going through the lungs in a minute's time. The cardiac output, basically how well does the heart perfuse the lungs. If you don't have the heart pumping blood to the lungs, there's no carbon dioxide level for the lungs to expel, okay? And also the metabolism of the body. The higher the metabolic rate, the more carbon dioxide is going to be produced that's going to end up traveling to the lung. Now I added here the function of the anesthesia machine, because if the anesthesia machine is not functioning properly, since that's going to be the source of both oxygen and the way that the body eliminates carbon dioxide, it can also affect our measurements of the carbon dioxide level. But as far as the physiologic factors, that's going to be ventilation, cardiac output, and metabolism from the body. Making sense so far? Now, how those are affecting the end-tidal carbon dioxide levels are expressed in this formulation here. Now I did this as a proportion, not an exact formula, but the end-tidal CO2 is going to be proportionate to the the cardiac output and the metabolism, which means as either cardiac output increases or metabolic rate increases, the carbon dioxide levels are going to increase in the blood. Okay. Now, the ventilation is inversely proportional, which means the faster the respiratory rate is, or the bigger the tidal volume is, the lower the carbon dioxide levels is. So they're going to be oppositely proportioned, okay? Now, cardiac output, remember, is a combination of the heart rate, how fast the heart beats, combined with the stroke volume, which is how much blood the pump pumps per heartbeat, okay? Metabolism, of course, is a cellular activity. So if either one of those increase, you're going to get increased carbon dioxide. Ventilation is actually a combination of the respiratory rate and the tidal volume, so how fast they breathe with how much air goes into the lungs and out of the lungs with each breath. Both are going to make a factor on the cardiac output. Now, a practical example is whenever you exercise. When you exercise, the metabolic rate of your cells are going to increase, carbon dioxide levels are going to increase as a result. Now, in addition to that, your heart rate's going to increase because it's going to be pumping blood for you, so that's going to also increase your carbon dioxide levels. So that there's not too much accumulation of carbon dioxide in your body, you start breathing faster, so your carbon dioxide levels will decrease back to normal range. So that's a really practical example of how these different factors affect the carbon dioxide levels for you guys, okay? Making sense so far. It's a basic quickie 101 version of carbon dioxide levels and how it's formed and the factors that influence it for us. Now, looking at the waveform for the end-tidal CO2, or the Capnograph, I should say, is going to be basically a rectangle. Now, one of the things I had to wrap my mind around is this is a graph of expiration, okay? It's tempting when you look at that graph to go up, that means they're inhaling. That's not the case. That's actually when they're exhaling. So when the graph goes up, the lungs are deflating at that time. So this is a measurement or a graph of expiration, okay? So down here, whenever it's baseline, this is called phase 1, That's whenever the animal is inhaling, okay? Now, at that point, there should be no carbon dioxide level at all. So this phase 1 number should always be 0, all right? Because you should be getting either pure oxygen in or very low carbon dioxide levels in if it's room air. Then at the beginning of expiration, when they're starting to exhale, that's called phase 2. Now there's a really steep incline initially. And this steep incline is usually corresponding with the expiration of air from the dead spaces of the airway system. So the endotracheal tubes, the trachea, the bronchi, and the bronchioles. None of those structures are involved with the gas exchange. So you get a really steep incline, and then you have more of a plateau. So phase 2 is the dead space expiration, then plateauing is the phase 3. This is representative of the alveolar concentration of the carbon dioxide, where the gas exchanges occurs. In phase 3, there should be a slight incline in the slope of that plateau, okay? Now the angle between phase 2 and phase 3, between the dead space expiration and alveolar expiration, is called the alpha angle. This should be a little bit steep, about 100 to 110 degrees. You don't have to actually measurement, but it's not going to be an exact square angle, okay? Now at the end of expiration, that's whenever they start to inhale, so you're going to get a rapid drop in the carbon dioxide levels when they inhale. That's phase 4. This angle between phase 3 and phase 4 is called the beta angle, and this is the point at which the end tidal CO2 measurement is measured. That's going to be what is the number on our machine, okay? This angle, this beta angle, should be about 90 degrees, okay? So this is the anatomy of the waveform that is generated with the capnograph. All right, making sense so far? All right, now on an actual machine, this is what it looks like. You got your ECG, you got your blood pressure monitor here, and down here you've got your capnograph. So you can see on inspiration is phase 1, you got a rapid increase in phase 2 upon expiration for the dead space they'd be emptying out. You got your alpha angle, which is a little bit obtuse, a little bit greater than 90 degrees. In phase 3, where you have the alveolar expiration, the alveolar concentrations that slowly increase to the end tidal CO2 measurement. Then you got your beta angle about 90 degrees, then you got this fast decline on the next inspiration that goes right back down to 0. Okay? So making sense for normal values. Now, normal end tidal CO2 should be between 35 and 45 millimeters of mercury. So that number that you're seeing on the machine should be between those values. If it's higher than that, there's more carbon dioxide levels than there should be. Lower than that, there's not enough carbon dioxide in the blood. And we'll talk about what happens with those values, okay? Are you ready for some examples? All right. No questions so far, or explaining everything pretty clearly for everybody? Good. Now this first example, the only monitor that we have here is the carbon dioxide level, the capnogram, okay? Now here is the block that shows the numbers for us. So here you have actually the carbon dioxide level, and here you have the respiratory rate, okay? So what we're seeing here is a pretty fast respiratory rate of 43 breaths per minute, and our carbon dioxide levels are at 27, much less than that 35 level here. And if you're looking here, you're seeing fast breaths with the peaks not going very far. It goes down to 0, but the breath is so fast, you're not really seeing much of an alveolar plateau in this situation. So this is an example of hyperventilation, okay? Now, anything that will make the animal breathe faster during anesthesia can be a cause of this. Okay, so if you see a low end tidal carbon dioxide, something that's driving that respiratory rate faster than it should be. Can you guys think of any examples?
Pain.
Pain. Wonderful, that's my first one too. Good, okay. Next one.
Too light.
Too light of anesthesia. But yeah, you're right in order, look at this. The anesthesia is too
I
light.
didn't look at it before,
Yeah.
I promise.
The other ones are not as intuitive. If there's hypoxemia, now this is a little bit misleading because low blood oxygen does not drive respiration until it's extremely severe. So this can be a reason for them to breathe fast, but it's not the initial thing you think about, okay? You can also have hyperthermia, okay? If they're too hot, or if they're going through malignant hyperthermia, or if they're running a fever, that can do that. And then a really unusual one would be metabolic acidosis. You got the diabetic ketoacidotic that's under anesthesia for some reason, or they have some huge amount of inflammation in the body because you have a septic abdomen and they're acidotic as a result of that. They're going to have a higher respiratory drive. But those are pretty unusual cases for you to have under anesthesia. So big ones are going to be pain, light plane of anesthesia, or low hyperthermia or fever, and hypoxemia are the main ones you're going to worry about. Okay. Now let's look at hypoventilation. So here you got your waveform. You can see there's a long expiratory plateau before they inhale and exhale again. And you see the respiratory rate is low at about 13. You're seeing that the end tidal CO2 is a bit high at this point here, okay? So what can cause breathing too slow?
Too deep.
Too deep of anesthesia, and really under anesthesia, that's going to be the main thing you're going to think about. The anesthetic plane is too deep. There are other causes like metabolic alkalosis or hypothermia and things like that.
What about like drugs we give, like propofol?
That's another thing that causes them to be too deep in anesthesia. So sudden bolus of propofol, you're right, that does cause apnea because they are too deep for it. So drug influence or too deep a plane of anesthesia. So whenever you see hypoventilation, it's usually right after induction where they're really in their deepest plane before the respiratory drive kicks off for you guys, okay? Making sense so far? Already good. Now this one I'm going to explain it because there's a lot of busyness to this monitor here. This section here is going to be your capnograph, okay? Now in this section here, you're seeing that the end tidal CO2 comes up here, and then it goes down, but it doesn't ever go back down to zero. And then it goes back up here to the plateau, then it comes down here, but it never goes back down to zero, okay? So this is a non-zero phase 1 or inspiratory capnograph, okay? So what this means is that there's still carbon dioxide in those tubes when that animal takes the next breath. So they're rebreathing expired CO2, okay? Now in this particular machine, you can see here's the end tidal CO2 volume, so that actually is a little bit higher than it should be. But here they actually have the monitor or the sensor so that you can measure the carbon dioxide level itself. And the fractional of the carbon dioxide is 29%, not zero. So what's going to happen whenever the patient is rebreathing expired air? Depends a little bit on what kind of anesthesia or machine we're using. If we're using a non-rebreathing system, so the small bags for the small animals, it means your oxygen flow is not high enough. It's not flushing the carbon dioxide from the previous breath out of those tubes before the animal takes the next breath, okay? Now, if you have the rebreathing system going on, you're on the circle system, so the bigger dogs that we're going to be using, that means there's something wrong with the anesthesia machine itself. The valves are not keeping things closed and keep things going unidirectional. Things are backflowing so that the expired air goes backwards back towards the patient, or nobody changed the soda lime when they should have, and you got really blue crystals in that soda lime container, okay? So if you're seeing this, you're thinking either a non-rebreathing, I'm going to increase my O2 rate, or second, something's wrong with my anesthesia machine, okay? So far, so good?
Question.
Yes, sir.
Would that happen too if you didn't put the correct size bag on the machine?
No,
Okay.
no, that's not going to make that happen. What's going to happen there is that they're going to have a lot more pressure whenever they exhale.
Yeah.
Okay? Alrighty, good. All right, now, phase 3 to 4 abnormalities. This is going to be the alveolar plateau and non-cause inspiration kind of abnormality. So you're going to see the end part of the curve. Now this is, I'm not seen yet, but if you do see it, it's not to panic. What you see is your baseline phase 1 is 0, comes up on the beginning of expiration, your alveolar plateau, and then instead of that sharp decline back down to 0, you're seeing just fluttering of the waveform as it goes down. Now these are actually cardiac oscillations. We don't really know why these happen completely, but they do tend to be associated with several things, such as negative intrathoracic pressure when they're inspiring again. That's why it happens in phase 3 to 4. If the respiratory rate is very low, or if they have a low inspiratory to expiratory ratio, so there is going to be a fast inspiration and long expiration kind of a thing. If there's low tidal volume, so they're having very small movements to their chest when they're breathing, sometimes they'll have these cardiac oscillations. Or if the muscles are really relaxed, and this is more important if you're doing anesthesia where you do a muscle paralysis as part of it and hooking them up to ventilators for us. Now if you see this, it's not the panic, it's actually considered a normal variation. It's not a problem with the patient or the anesthesia machine. So if you see these little oscillations in the expiratory or inspiratory phase of the curve, don't be worried about them, okay? Alrighty, any questions so far? Alrighty, cool. Alrighty, now, here is an interesting thing they also want to be very aware of too, where you have is phase 0 to be abnormal, then or to be your phase 1 being 0, your expiration being a good curve up or a sharp incline up, and then you have your alveolar plateau just kind of blend down without oscillations down back to 0. So you have a very obtuse, a very large blunted beta angle, and you also have a loss of that sharp demarcation between phase 3 and phase 4. Now, when this happens, this means that there's a leak somewhere in their system, which means that some of the gas is leaving the system before the patient starts to inhale for the next breath. So if you see this gradual decline in the plateau down back to zero, start looking at your connections. Did the endotracheal tubes disconnect from the anesthesia machine? Is there a leak in one of the tubes or a hole in one of the tubes or things like that? Does somebody forget to put the rebreathing bag on the machine and they're just expelling out the rest of the system and things like that? So if you see this slow gradual decline, that usually means there's a leak somewhere in the system.
If it's not inflated enough, the cuff, would that also cause that? Is that a place to check?
Yeah, that's another place to like that. So a loose endotracheal cuff, good question. Okay. All right, any questions about this type of a curve? All righty, cool. Alrighty, now this one here, it's really not, didn't have any other way to title except for expiratory obstruction, so I'm giving you the answer. There's an obstruction somewhere in the airway, and what we're seeing here, as opposed to a nice sharp increase upon the beginning of expiration, it's a slow, gradual slope, and you're having a more blunted alpha angle here. So if you think about it, if there's an obstruction in the tubes or in the airways, it's like breathing through a straw. So you're gonna it's gonna take longer time for all that air to empty out of the lungs. So you have a gradual slope coming up here. So if you see this gradual slope, start thinking, is there a kink in the endotracheal tube? The dog neck gets flexed too far, now you got the tube kinked. Or is there a bend in the tube somewhere? Is there a mucus plug in the tube? One of the tubes in the anesthesia machine got stepped on or kinked or something like that. Can actually happen with also some lung disease. So if you got lung parenchymal disease that is causing obstruction of the airways, it can do that as well. But usually those patients are going to be abnormal before you get them under anesthesia. So if you see this gradual upslope in the curve, then start thinking that there's a kink somewhere, maybe change the endotracheal tube or change the position of the animal's neck, things like that. Okay? Alrighty, cool. Alrighty, now, what if you get no reading at all? You put them up, hook them into the machine, and you get no reading at all. Lots of reasons. Remember, there's three main things that are going to be affecting this for us. Okay, we're going to have abnormal machine, animal not breathing, or there's no blood going to the lungs to expel the carbon dioxide. So think of those three main categories to see what's going on for us. Okay, so if there's improper machine, you've got improper intubation. Endotracheal tube went into the esophagus, and you're not in the trachea itself. Okay. Or the anesthesia machine got disconnected. You got the tube there, and then you got the hoses over here next to the patient on the table, things like that. The animal's not breathing at all, so there's no gas exchange going past the center, kind of a thing for us, okay? Now, it can also be something wrong with the airway itself, so there's a complete obstruction where you got a complete, not just a kink, but also now a complete fold, where there's no air that can pass through the endotracheal tube for some reason. Now, they can also have decreased blood flow to the lungs. Some we have a massive pulmonary embolism, and that can be a very serious kind of a thing. And those usually for really sick patients, so we usually are not going to worry about encountering that one. Now, the really concerning thing is you have a sudden drop in cardiac output, which means blood is not able to get to the lungs very well. So there's a lot of carbon dioxide in the body, but it's not getting to the lungs to be expired. So you've got sudden massive blood loss. You've got acute hypotension where there's just massive vasodilation going on all over the place, or you have an extreme severe arrhythmia that's going on where not many of the heartbeats are actually pumping blood the way that it should be. And of course, the most concerning is the animal just died. So always be if you get no reading, as always, don't think the machine is going screwy. Check to be sure the animal is alive, and then back steady from there for you guys. Okay. So let's go through a few of those examples and see if we can see if of all these possibilities, which ones are going to be the most likely. Okay. So this one here, you've got a nice normal capnograph, nice normal capnograph, nice normal capnograph, and then nothing. So what kind of things can cause this kind of a thing to occur?
The tube disconnected.
Good. Very good. That's a good one. What else?
Apnea.
Yeah. The animal all of a sudden stopped breathing for some reason. Okay. What else happened? So I just put it on the neck, and I want the neck to be kind of ventral flex because I'm going to be doing something on top of that. So yeah, obstructed the tracheal tube, they can't breathe at all. What else?
Gonna be death.
Yeah, the damn
Yeah.
animal just died.
Yeah.
Exactly. So you see this at all nuts, you know, or maybe a more stronger word depending on how you like.
And how
to look
long
at
it lasts,
movie.
right?
Exactly right. But look at the patient, be sure it's still alive, and then backtrack from there, see what the airway integrity is, make sure that his machine is still connected. Okay. All right, here's one here too. So here's the capnograph right here. Look, it's pretty much a flat line here, okay? So what's going on here? What kind of possibilities here?
Would you call that without a breath first, the That's what you call them, the cardiac oscillations?
No, because,
You need the first breath
yeah,
first.
so these look like those little oscillations, but you need a breath first in order to see that. So this one here, there's not even a registering a breath just yet, okay? So what can cause just a flat line at 0 of the capnograph in this patient? Apnea, they're not breathing very well, we just give them a dose of propofol, now they stop breathing, okay?
Cause he has a heart.
Yeah, exactly, he's got a
He's
heartbeat,
alive.
he's got pulse oxygenation, he's got good blood
Machine
pressure.
malfunction, like aren't connected.
Right, so there could be a
Disconnected.
disconnected tube, right, what else? You just intubated them and they're taking a breath and you can see them breathing, but you're getting 0.
It's in the esophagus.
It's in the esophagus.
Esophagus.
Esophageal intubation is another really good one for it, right? So don't worry in this case that you've got cardiac arrest because you got heart beating, you got blood pressure, you've got or pulse oxygenation, you got blood pressure. So you can tell that the animal's alive. Then you have to worry about the placement of the tube, the integrity of the tube, or something like that in this situation for us. Awesome. Okay, you guys are doing really good. See, once you understand how the waveforms are generated, I think it's very almost intuitive to understand why the different
It's all
waveforms.
about
occur.
physiology.
Exactly. Okay, what about this one here? Now, we just have the capnogram, where you're seeing that a nice normal capnograph here, and then a little bit lower, 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 lower. What's going on here?
Too deep?
You get a very deep level of anesthesia, and they're going hypotensive, or they're going, not really hypoventilation, because you can still, they're breathing well enough, but very, very shallow tidal volumes are a possibility, right? What else?
Yeah, or
Yeah, they could have the heart just stop, so there's no blood now flowing to the lungs, but the animal's still breathing. So with each subsequent breath, there's less and less carbon dioxide in those alveoli to expire. So sudden cardiac death would be a good one. What else?
The tube is slowly falling off.
You kind of,
Leaks
usually with a
every
leak,
single one.
yeah, usually with leaks, so you're gonna get a slower, a blunted, phase 3 to phase 4 angle, so you're not seeing that here. So I don't think you have an anesthesia leak in this
Yeah.
situation, okay? What else can do that?
Is the tube not inflated or not?
Again, that would be a leak, and so I don't think that's the case here, okay? So you're not thinking leakage in this situation, you're thinking,
Someone's
okay.
breathing too fast for them.
No, well, that'd be, and
Pumping
if
back.
that's the case, you'd see things would be closer together, so you're not seeing a change in the rate here, okay? So what else will cause decreased carbon dioxide reaching the lungs? Let's think of that.
PTE.
Yeah, pulmonary thromboembolism, so massive embolism in the lungs, where you're blocking now blood flow to the lungs, so you don't have as much carbon dioxide going there. What else?
Hypotension?
Great and wonderful. You just reverse the dexdometor, and all of a sudden all the arteries are vasodilated, so you have a sudden drop in blood pressure. What else can cause a sudden drop in blood pressure
Drugs.
besides drugs?
Always the
Blood loss.
anaphylaxis.
What's that?
Blood loss.
Blood loss,
Yeah.
exactly, right. You got a splenic vessel that you nicked and it's all bleeding all over the place. So you didn't realize you dropped an ovarian pedicle and it's all bleeding all over the place. Okay, something like that. Exactly, right, okay. What else? One other thing that you probably should have in your mind, and this is unfortunate because I don't have an ECG to see at the same time. Arrhythmias, severe arrhythmias can also cause a decrease in cardiac output, so you don't get the blood going to the lungs very well, okay? Awesome, awesome, great. Any questions about any of that so far? Okay, great, so that's pretty much all the examples that I think are gonna be the major abnormalities we're gonna encounter. Now, I'm just gonna put a little plug here, because I want to show you this clinician's brief article. Honestly, all the images, except for one that I had today, were based from this article. I actually kind of scavenged from it, so I want to reference it, because this is basically where my references came from. But it's a wonderful article for you to review capnography, go through the different waveforms, the interpretation of the waveforms, and how it's formed, and things like that for us. So this is it's an image gallery, so it's actually just a series of images that I just showed you, and it gives you a little explanation for those, okay? The author is Rachel Reed, and this is from a May 2017 clinician's brief article, but if you Google the clinician's brief online and you go to capnography, this comes up right away. So it's a really nice, quick reference, takes 5 to 10 minutes to read, and this is what made it really easy to put this lecture together, because it has really great overview of what's going on, there's a great summary of what's going on, and it's a great reference for you to come back to, besides this lecture, to interpret capnography for you guys, okay? Alrighty, any questions about anything for me? Yeah.
I might have missed this, so I'm sorry if this is repeated. What if the tube is too far down into the airway?
So if you have something, you're gonna have only part of the lung to be intubated, so you're gonna have, probably in that situation,
Or too long or too small.
yeah,
Sometimes
the probably
that-
going down there, yeah, I'm trying to think which way the carbon dioxide levels, because with the lung that's gonna be aerated, is gonna still get enough carbon dioxide into it, so you
They usually
probably
are
won't affect
like
the entire
cyanotic when
CO2.
that happens.
Yeah.
They are.
Yeah, they usually get light from anesthesia because they're not getting enough into their system, so they're usually probably a light anesthesia, they're probably gonna be hyperventilating, and probably have lower carbon dioxide levels because of that. Only because they're bleeding off that little bit that's in the lung that is gonna be intubated for us there.
And what about like our obese patients? That sometimes it's hard to figure out, are they, when their pulse ox are like 90 and you're like, is it that they're just on their side and they're,
Yeah, in that
Active.
situation, the biggest thing with obesity is you're gonna have decreased tidal volume, so your ventilation rate's gonna go down, and they're gonna tend to be hypercapnic, your end tidal CO2 is gonna go up with the obese patients, okay?
and then an update, Chris is ordering one for right now, another capnograph,
Okay,
because we can only have one type of machine, and so we're gonna make sure it works well before we order multiple. So if
sounds good.
he'll need some input when we get them in and start using them,
Mhm.
how functional they are, because sometimes they can be a little finicky.
Yeah, that's the only bad sign, but any of the monitors we have can be finicky, like the pulse ox is finicky and things like that. So they can be finicky, but I think there's gonna be a lot of added value, because since I've been doing the capnography and looking at the machines, a lot of our patients are hypoventilating and we don't realize it when we're looking just at pulse ox itself. Ooh, this is a good question too. I talked about the circulation where you got the carbon dioxide coming into the blood, you got the blue blood coming back to the heart, and also low oxygenation blood coming back to the heart and going to the lungs. What makes an animal cyanotic? What makes the gums blue? High carbon dioxide or low oxygen? Low oxygen, that's
Yeah.
right, okay. Wanna make sure you get that clear. In other words, you cannot tell by their gum color, are they hypercapnic or not? That, the low blood oxygen, the deoxygenated hemoglobin has a deeper, darker color, and that's what makes them cyanotic. The level of carbon dioxide can be sky high, and they can be pink as can be, okay? So don't rely on gum color to see if they are ventilating well enough. Yes,
You might be going to talk about this, unless you're done.
I'm done, yeah.
Can we talk about CPR, how we use it for CPR?
Okay, now for CPR, remember the components that are gonna make up the carbon dioxide levels are gonna be a combination of ventilation and also cardiac output. So if our ventilation is consistent during CPR, because we've got somebody given a consistent rate and volume of breathing, that means that factor is not gonna be influencing our carbon dioxide level. So if we're gonna see an increase in carbon dioxide level, it's because we're getting better blood flow from the heart to the lungs, okay? So whenever we're doing that, we're gonna have good cardiac compressions. Believe it or not, it's considered really good cardiac compressions if your end tidal CO2 is 15 or more. It's an ungodly low number for anesthesia.
Yeah.
But if you're getting 15 or more, that means you're getting blood flow from that heart to the lungs, and from the lungs to the body, and from the body back to the heart, okay? But you want that number to be 15 or more to say, I've got effective cardiac compressions.
So we
Now,
should be trying to
another-
use capnography for every code that we.
absolutely, yeah. Now, another thing about the end tidal CO2, if you're doing your cardiac and compressions, and you're seeing, okay, 15, 16, 17 carbon dioxide, all of a sudden it goes up to 50, what just happened?
Patient breathe. Or
No, the heart start coming back to life. So the heart is a much better function of getting cardiac output to the lungs. So if you see a sudden increase in carbon dioxide level, it's usually high, because a lot of carbon dioxide builds up in CPR, right, or whenever there's cardiac arrest. Then all of a sudden the heart probably came back. You don't need your EC machine or your stethoscope to tell you the heart came back,
Thanks.
okay?
And you can also see to make sure you're giving enough recoil too, right? Because like if it's just staying flat, you're not letting it go up.
Well, the recoil is gonna be hard to see because your cardiac and compressions are gonna be compressing the heart, and so is the ventilation itself. So I wouldn't use the waveform to say, am I having good recoil from the chest? And because that's gonna be mixed with the respiration, it's gonna be hard to see. It's gonna be a very irregular waveform. I get more by the number during CPR than I would by what the waveform looks like. But yeah, but that's a good thing. So if our cardiac compressions are effective, we want a CO2, end tidal CO2 of 15 or more. And if we see a sudden increase in the CO2, that usually means the heart came back, and we can stop our compressions and then reevaluate the patient. Making sense for you guys? All right. Any other questions?
I think the machine being finicky is a good point, because I feel like everyone here who does anesthesia for blood work or for dentals and surgeries is pretty comfortable with pulse ox. And the pulse ox is finicky all the time, but we don't just give up on it, right? We're comfortable enough that we continue to try to use it. So hopefully the more we use the capnograph, even though they're finicky
I think
sometimes, we're not gonna be like, oh, it just doesn't work, it's
Each
finicky.
piece is $2,000, so it's not like we wanna spend 10,000 and then say this isn't working and do a different direction. So I'm not saying no, I'm just saying we wanna make sure before we
Oh,
invest
right.
in these ones.
Right, but that's a good point,
Yeah.
Riker,
Yeah.
all our monitors
Yeah.
have
Yeah.
finickiness to it,
Right.
so let's not use it being finicky as a deterrent that we're gonna not wanna use it, yeah, we still.
No,
wanna
I'm saying then we would explore possible others.
Right, if
So-
it's too finicky, if it's too unreliable, then we have to think about other versions. There's a couple different types of capnography sensors. One are inline, where it just kind of picks up the gas as it goes past of it. The other ones are gonna be external, which means they're gonna suction a little bit of the gas right from the endotracheal tube. Both can be clogged, some could get moisture on them and kind of interfere with the measurements and things like that, so they both can be finicky. But there's a couple of different types of capnograph monitor, or sensors that they have out there for us, either inline or outline.
Is there any way to know, like, if your anesthesia machine's fine, your patient is fine, but it's the capnograph itself, like, say it's totally done and it needs to be replaced, like, are you just gonna get no readings at all?
Get no readings at
It's
all.
just gonna be.
Right, because
That's
it's not
the
gonna pick up
fun
the
part.
readings,
You know
it's
what I
gonna
mean?
be
It's
just
like, how do we
zero,
know
right.
when it's just like, okay, this one needs to go, you know?
Yeah, it's gonna be this
Like
one. and it's
consistently,
not
every single
reading,
patient's
yeah.
just not reading.
Exactly, and like with any other monitors, you look at
Yeah.
all the parameters, and if everything else fits with the stabilization except that, then it's probably the monitor. So, it's one of those things that you, kind of troubleshoot and look in context.
And I would say too, like, especially with all the more experienced people in this room, I remember feeling that as a new doctor, and then that's probably the number one thing I hear from new, staff members, is their discomfort of, is the machine being finicky? How do I know? When do I turn up? When do I turn down? So as you have these newer people in the rooms, making sure you accentuate, like, this is not as exact as everyone wants it to be.
Yeah, and if you ever
And
are
explaining
concerned,
why you're thinking one way or the other.
just say something.
Yeah.
Like, I mean, just say it.
Yeah,
Right, there's a lot of people in the room, we're a team in that room,
Alright.
yeah.
and we all are there to back each other up. So if one person has discomfort or uncertainty, you know, get everybody else involved, ask questions, speak up, that's what we're there for each
Right,
other.
even if it's like a silly answer, like, don't, I mean,
Yeah.
that's
Yeah.
what we're.
Or just being like, hey, I know it's reading 50% on pulse ox, but I don't think it's true because X, Y, Z.
Capnograph is 40.
Versus just going, these stupid machines.
Or
And then
say,
like, panicking.
Hey, just reassure me, because this says 15
Yeah.
and I don't
Why are
really
you not?
like that.
Yeah.
Is there
You know,
any
Because that's how
correlation
I'm
between
gonna
what the
be.
pulse ox says and the capnograph says? Like, say the pulse ox is 50, but your capnograph is 40,
Okay.
like, you good?
Good question, yeah, the question is there
Is
any
it
correlation
slipping?
between capnograph and the pulse ox? And the
Yeah.
answer is no.
Not at all.
We're measuring different things. Carbon dioxide is way more soluble than, or actually, it goes between the membranes so much faster, it's almost instantaneous transfer from the blood to the alveoli and from the alveoli on out. Hemoglobin has to absorb the oxygen level, so you're measuring different things. The biggest influence under anesthesia for the capnograph is going to be ventilation, not necessarily cardiac output or metabolism. The pulse ox is going to be a factor of not just the oxygen level, but also how well oxygen gets across the alveolar membrane and into the blood, and how well the blood absorbs it. So we're measuring two different things.
So really,
So you can't say my capnograph is for crap and I got a great pulse ox, that my patient's okay. That patient could be completely apneic and hypercapnic at the wazoo, and their oxygen levels are gonna be just fine.
For
So
now.
you can't.
Disease
right,
process.
For now.
Right, you're measuring different things.
a lot of disease processes would be defined by that, like if you have no blood because you're anemic or you got hit by a car versus if you have asthma and you can't expel your air properly, correct? Like versus,
So you have pulmonary dysfunction. If you have pulmonary dysfunction, let's say you have a lot of thickening in the airways, or you have pneumonia going on, so there's not gonna be an easy diffusion of the oxygen across the alveolar membrane. Carbon dioxide is so diffusible that it goes across almost anything, okay? So in pneumonia, you're gonna have a low pulse ox, because oxygen is gonna have a much more difficult time traversing that alveolar membrane, but you can ventilate just well and your carbon dioxide levels will be fine. So you can ventilate well, but your oxygen oxygenation can be for crap if you have an impaired alveolar membrane diffusion process, okay? Is that making sense for you guys? Remember your respiratory physiology?
God,
I think it's
hated it.
fun.
Oh,
It's like
God.
acid-based stuff.
It
I don't
is. I
remember
love
it,
it.
but when I learn it, I find it so
I know, I
fascinating.
like it fascinating too, yeah, we don't do many blood gases or anything like that, but I love that too, but it, you know, the air exchange, since carbon dioxide is so diffusible across the membranes, it's more just a reflection of ventilation, not how permeable the alveolar membrane is. That's gonna be your oxygen content, so there's different things that you're measuring with that. Okay?
Something about VQ mismatch.
VQ, yeah,
Oh,
ventilation,
God.
perfusion,
Yeah.
mismatch,
The
yes,
biochemistry
exactly.
of it all, oh,
Right.
blows my mind.
Do you know
Alright.
which kind we're getting? The inline one or?
Oh, whichever one goes with the machine.
Oh, okay.
Yeah, that's on the machine, I have to look to see what's going on. I think we have the, inline one. Yeah, they're a little bit bulkier and all that kind of stuff, that's what these are. The outline ones are not as bulky, they're a little bit lighter, but they also have to suck a sample from the endotracheal tube to get the reading. It's not gonna be a direct reading off the expired air.
Are they less accurate in that way?
I'm not sure which is more accurate or not, but those seem to be pretty popular, so, yeah.
Does
Anything is more accurate than what we used to.
Oh, yeah.
Which is nothing.
Right, yeah, anything more accurate than nothing, right? Very
We've
good.
been playing with the surgery.
All right, wonderful.
We've been playing with that one.
Yeah.
Yeah.
Is there anything else that like we didn't have, is there a reason why we didn't have this for a long time?
I think it was mostly,
See,
We
it's
like,
had one and couldn't get it to work well,
yeah,
and then
we-
we've had different machines.
yeah, I think the technology earlier was not
Yeah.
that great, and,
Oh, okay.
it was extremely finicky, and we never relieved it, systems never believed it or really relied on it, we just said, why even use it?
Okay.
But the technology's getting better now.
And
it's
I
gonna
mean,
be-
I feel like our staff is a little bit more open-minded to new things now too, like, you know, they wouldn't.
That, and also that the standard of care has increased.
Yeah.
Right.
Whenever I first graduated, we were lucky to have a respirometer on the patient, let alone
A
anything else.
respirometer?
Yeah, so we could tell us breathing, but we didn't have no ECG, no
And you guys
pulse
just have to
oximetry,
be like,
no carbon dioxide, no
Strain
blood
this
pressure
palate
monitor.
thing.
Yeah.
So the standards
Oh
of
my
care has
God.
increased too, making this a
Yeah.
little bit more, pushed to be able to want to do for us, okay?
So is this like check all the boxes for everything you can monitor during anesthesia then?
The base, yeah, the biggest.
Or
ones,
other
yeah.
than like,
Except in
Like-
our one.
Yeah, there's other
right,
things you can
except for
monitor.
like, what's the thing you can put in the ET tube, like measure?
Yeah, you can measure the
Body
anesthetic
temperature and
levels, you
stuff.
can measure you can measure the oxygen levels, you can measure the anesthetic levels, you can measure the carbon dioxide levels, so there's other things and gases you can
I'm
sample
just
with the
curious.
sensors.
'cause-
Right, you could do direct blood pressure monitoring rather than
Oh, that's
indirect
what
blood
Jess
pressure
said she does.
monitoring.
Jess was like, I
Our
pressed it for central line or our
Yeah.
line, and I got like
Exactly, right.
time.
Yeah.
You know,
Blood
and
pressure
she's
curve,
sure.
exactly.
She also like,
So
it's
you do
funny, like
things, but-
people flip out, she's like, trust me, you can do it when your capnograph isn't working, it's
Right.
okay.
Right, exactly. Right, so there's other things you can monitor, but
I was
as far as the general practitioner level, this is gonna be our AD.
Yeah.
Pretty much a
However, like you said, monitoring is the most important thing, hands on patients, listening, our minds.
Looking.
None of the monitors replace hands on the patient.
Yep.
Right? Just like we never look at lab work without knowing what the animal's doing and the physical exam findings, you always look at it in context.
Frankly, I always distrust the machine before I think my patient is doing poorly.
Right, now, of course, our
Unless it's really
default is the
obvious,
machine's
yeah.
being finicky because they're finicky so often, but don't
Right,
forget,
I
you
always
gotta
am
look
like,
at the patient
no, let's check
first.
my patient. I
Yeah,
don't
be
know
sure
if
the
I trust
patient's
machine.
alive before you go fussing with the machine.
Right.
Right? Alrighty, good. Any other questions from you guys? Alright, wonderful, thanks. I really enjoyed doing this, great. Have a good night.
He's so good. Look at him.
Between